My topic today is lasers in contemporary implant and restorative dentistry, a microscopic perspective. I want to thank Team Atlanta, Eddie Salama, and Tyler for this tremendous opportunity. It truly is one of the highlights of my professional career. I have a private practice in North Vancouver, British Columbia, and for the next 40 minutes exactly, I'm going to share with you some of the highlights of my life involving microscopes and lasers in dentistry. In the lecture, we're going to cover four things. I'm going to cover a very brief introduction. We're going to cover lasers as an adjunct to aesthetic dentistry. And for the last 30 minutes or so, I'm going to cover two topics: lasers as they are an adjunct to implant dentistry, and the very exciting role of lasers in the role of peri-implantitis. We begin with an introduction. There's a myriad of lasers out there, confusing indeed. And when you look back at Gordon Christensen in 2008 when comparing diode lasers and electrosurge, he asked, are the advantages of a diode laser enough to compensate for the increase in cost? At that time, those little units were about $15,000, and they're now down around $3,000. The authors of this article asked, some practitioners have made lasers their main interest in the profession to support the concept strongly, while others call the technology a technology looking for a use. So are lasers looking for an application? Well, I've written articles on comparing the diode laser to electrosurge, how it is a replacement for that, how sometimes lasers in fact can be a replacement for traditional methods, and how they can be used in the role of aesthetic and implant dentistry. There are a myriad of lasers out there, and for sake of brevity, I'm going to focus today just on two topics: the diode laser on your left and the all-tissue lasers on the right. Dr. Stephen Brown, who's in the third row, will talk about the Nd:YAG laser and the exciting role of it in periodontal disease and also for the treatment of peri-implantitis tomorrow. When you look at lasers, the green lasers are soft tissue lasers primarily. The diodes are the small portable lasers that we have seen grow in very many practices. Nd:YAG lasers and CO2 are primarily soft tissue, although there is a new CO2 laser that does cut all tissue. The erbium lasers that you see in the orange are all tissue lasers, and they're able to cut not only soft tissue, but cementum, dentin, bone, caries, and so they're able to cut all materials. Diode lasers have become popular over the last decade because they're portable, robust, inexpensive, and efficient. They can be used, unlike electrosurge, around metals. They can be used as an alternative to retraction cord. They can be used for small surgical procedures such as frenectomies and fibromas, and indeed they can be used to control vascular lesions such as venous lakes. Erbium lasers are larger, they're more expensive, and they are all tissue. They can cut everything. They gained popularity in the early years of the 2000s for their ability to cut anesthetic-reduced restorations. They can be used to remove bone both in a closed flap and open flap situation. And they have the exciting opportunity to be able to be used to remove porcelain veneers in under a minute. So let's focus a little bit after that introduction on perhaps a couple things that lasers might do in aesthetics. Most of the time nowadays we are using a retraction cord as our tissue management device, but lasers can be used as an alternative or as an adjunct to create not only ovate pontics, but they can also be used to create tissue retraction in these particular cases. You can take your impression either digitally or, in this particular case, traditionally, and the final restorations are placed where we had a frenectomy, some soft tissue recontouring, and osseous recontouring on the lateral incisors as well. When you look at the controversial topic of closed flap remodeling, we just saw in Sonia's beautiful lecture that 90% of patients have 1 millimeter or less of facial bone. Coyce has shown that that can be removed intrasulcularly with a Wiedelstadt chisel. So why can a laser not be used as well? We can shorten the length of healing time when we do first a gingivectomy and then an intrasulcular osseous recontouring just on the facial aspects, not going into the interpupillar region, and in many situations reduce the healing time to 4 to 6 weeks. We then provide beautiful aesthetic and functional restorations with a minimal downtime. At times we are required to shave down or plasti down tissue. This can be happening on a free gingival graft that's too thick. It can also happen in situations where old crowns are removed and an existing diastema is present. An all-tissue laser like the BioLase I+ here can be used to plane down or plasti the tissue and create a more ideal shape to the papilla. It's got water, and you can literally just contour the tissue to where you want. It's like painting. 2 weeks later, the tissue has a much more improved appearance. And you can see on the left-hand side, pre-op, immediate post-op, healing, and the final restorations immediately post-op and after healing. Laser recontouring and smile recontouring was also done with the lasers in this particular case. I've written a number of articles on the role of erbium lasers in porcelain veneer removal. In fact, David asked me to come to Puerto Rico for the AAED and lecture on porcelain removal in under 60 seconds. I used the research from Morford and their group at UCSF and this Turkish group, which showed that laminate veneers could be removed with all tissue cutting lasers, erbium lasers. I know this never happens in your practice, but in my practice, occasionally a veneer is bonded wrong, it has caries, it fractures, and it would be nice to remove that porcelain bonded restoration with ease. That first study was followed up by a second one in the Journal of Cosmetic Dentistry, and often we're able to remove Emax restorations and keep them intact. Pressed feldspathic restorations, unfortunately, will crack in many instances. So let's look at a case which required replacement. 2 lower incisors, one was fractured, one had decay, and you use an erbium laser which transmits through the porcelain bonded restoration. It interacts with the silane bond, causing some expansion, and after 45 to 60 seconds at about 6 watts of energy, with the water cooling the tooth so there's no pulpal temperature rise, we're able to loosen that bond and then mechanically remove these, often with a curette or some other means. You can see here we're using the laser over top, and as long as the porcelain is about 2 millimeters or thinner, we're able to remove these restorations. You'll see on the 4th attempt here, I'm able to catch a purchase and remove the veneer. On the second one, we're able to remove it in just 1 shot, just with a mechanical removal after loosening the veneer itself. These are Emax restorations that were removed in 1 piece. They were provisionalized, and then final restorations were placed. Let's focus now in the last 30 minutes or so on the role of lasers and implants. There are many of you who are worldwide experts in implantology, and I'm going to show you where perhaps the lasers could be used for a variety of things. Georgios Romanos wrote an excellent article in 2013 where he identified some particular aspects of dentistry that could be improved by lasers, including peri-implantitis therapy, manipulation of soft tissue, using a laser, an all-tissue laser to cut osteotomies, accelerating osseointegration. Diode lasers are excellent at low levels in wound healing and for hemostasis, and indeed photodynamic therapy was something else he discussed. I like to categorize the role of lasers in implant dentistry by the stage of the procedure they're used in. So for instance, prior to placement, lasers can be used to disinfect, detoxify, and degranulate extraction sockets. We've seen all-tissue lasers be used for sinus lifts, and during implant placement for things such as flaps, osteotomies, and indeed decortication for GBR. After implant placement, low-level therapy has been a tremendous interest in the last 5 years as new evidence shows how valuable it can be for wound inhibition, for pain inhibition, for wound healing, and also for neurogenic pain. We can use all-tissue lasers for leveling bone around fixtures, and we can use lasers during the uncovery process, both for a traditional manhole and trapdoor uncovery. After prosthetics, sometimes when cases like Sonia showed where soft tissue perhaps is impeding the insertion of a cementable crown, lasers can be used. And exciting enough, they are used now for the treatment of peri-implantitis. Because of brevity, I'm going to cover just a few of these things, and I'll share with you some clinical cases and how we use lasers in our practice. Let's start with the first one, being disinfection and degranulation. Ed Cusick, in this study in 2011, looked at the role of the lasers in extraction sockets. He took out teeth and compared the bacterial counts immediately before and immediately after using lasers and found there were no traces of virulent bacteria in those sites. Indeed, in this particular study, they found that immediate implants could be done at the same success rate as those in healed sites if a laser was used in combination with antibiotics, curettage, and 90% hydrogen peroxide. So let's look at a clinical case of my own. Here's a lower second molar on the left-hand side with a very deep probing on the distal. You can see the probing measurement measured about 12 millimeters here, and the tooth had to be extracted. You see the extraction here has occurred, and when you look at the extraction site, not only do we have a site that is infected, we also have granulation tissue present. When we look at the cause of the loss of this tooth, you can see at low magnification a gold crown. And as we look at the operating microscope, where Nazari and Maxime are going to spend some time showing you the miracles of magnification, you can see as we progress through 5 times magnification the clarity of the crack, the vertical fracture. 8 times mag, 13 times mag, and finally 19 times mag with the tremendous view that's offered to you by the operating microscope. As we return back to the socket and we realize we have to clean this, many of you will use curettes and some method of removing it. The first step is to degranulate the socket. We use an erbium laser, 4 to 5 watts of energy with a lot of water, and we can peel the granulation tissue off the bone. This is an end cutting tip, which most of the energy comes directly out of the tip itself. We can use this in combination with curettes to remove the granulation tissue. At this point, we bring in a radially firing tip where 85% of the energy goes laterally. And you can see tremendous photoacoustic streaming happening here, which is responsible for these microexplosions that will immediately kill bacteria. I want to show you that again in slow motion to show you the tremendous photoacoustic streaming that's happening here with the microexplosions occurring in the extraction socket. When you combine this with degranulation on the external epithelium, you can create a nice site for your graft. Regardless of what you use, in this case an allograft and a resorbable membrane, you are able to close this site and return another day. Lasers can be used for disinfection, in fact, in implant cases, and I show you this as a precursor to what I'm going to show you a little later on. This particular patient came from another dentist. She'd had an implant placed 3 years previously, but had never had it restored because of persistent pain. She came to see me, and upon the cone beam, you can see that there is a significant radiolucent area on the buccal. The other slice view here shows you the radiolucent area on the buccal, and the decision was made to open it up and see what we had because there was chronic exudate coming out. One of the nice things lasers can do is make an incision that is relatively free of blood. Because of the fine spray, it just creates a mist which gently washes away the blood, unlike a turbine where the splatter is quite excessive. One negative thing with implants is it creates a zone of ablation that is more difficult to suture across again upon closure because there's no primary healing. It's actually a little bit of secondary healing. When you look at the site here, I'm making sure that I get right down to the periosteum. Opening it up, you can see an implant underneath. We then did a full flap, attached a smart peg, and the ISQ, surprisingly, was between 75 and 79 on this particular implant. We raised a full flap, and as you'll see here, we're using the same laser to degranulate and to disinfect around the implant threads. This is typically a very difficult thing to do, and one of the most difficult things in peri-implantitis is the detoxification process. You can see both at low mag on the left and higher magnification under the operating microscope on the right how the soft tissue can be removed from within the threads itself. The water cools the implant and you get a rise in pulpal temperature around the implant of up only about 3 degrees Celsius. Immediately afterwards, you had a circumferential defect, and I asked the patient at this point what she would like to do. And she was so tired of the implant, she said, "I just want it removed." So we then proceeded to take the torque wrench, go counterclockwise, and we were able to relatively easily remove the implant itself. You can see there the break of the bond, and here at higher magnification, a little blurry, you can see how we can remove the fixture. One of the beauties of the operating microscope is the ability to videotape in all areas of the mouth. External videotape machines are not that easy to utilize for posterior restorations. At this point, you can see there's a little bit of granulation tissue, particularly on the lingual, where I wasn't able to get into as easier. And you can see the implant and the lingual cortical plate was what was really holding it in. And look how clean the threads are on the buccal. This was just a minute or 2 minutes of use with the laser. The patient decided they just wanted to have it disinfected, so we did this with a radially firing tip. And then after disinfecting, she said, "I don't want any grafting, I don't want to pay for anything else." We just applied a collagen sponge into the site and closed it up. I present this to you just so you have some idea where the lasers could be used for peri-implantitis when we talk about it in the last portion of my lecture. Traditionally, for guided bone regeneration, we are forced to go decortication with burrs. Kessler and his group have showed that with using a laser, an all-tissue laser, there's an increase in the release of PDGF from within the bone marrow spaces. And they postulated that this mechanism might explain why erbium laser radiation enhances and improves the early healing of osteotomy sites. Indeed, when you look at this particular case, I come from Canada, just as Sonia does, and our next speaker is coming from Montreal. We are proud of our sport that's called hockey. It's really good for dentistry. This particular patient took a puck to the mouth and damaged 10 teeth. A year later came back, and you could see the tremendous resorption that had occurred on the premolar made it unrestorable. So at this point, what we did is we tried to do an immediate implant for him, and you can see here the site is having active infection going on. A flap was raised. The tooth was actually simply removed through most of the buccal bone being lost. You can see afterwards a defect here, and at this point we're going to bring over a laser to degranulate and disinfect the bacteria and the curette the soft tissue out. You can see at high magnification here with the BioLase I+, and you can see here we're just stripping away the granulation tissue as I showed you earlier. The water keeps the site clean, and we're able to peel the tissue off without the use of curettes. After the soft tissue has been removed, we have to turn our attention to decortication of the site. We use the same tip, and unlike with a burr, we just use a lot of water here. We'll actually make little indentations and puncture marks through the lamellar bone into the marrow spaces. This releases osteogenic potentials of the cells within the marrow spaces, and they can be released to help you with your grafting procedure. And you can see the release of the cells right here. At this point, I brought over a piezo, create an osteotomy in the lingual bone. You can see at high magnification here, the placement of the implants. And of course, we're going to have some thread exposures on the buccal. Everybody will handle this differently. We decorticated it again. I grabbed some osseous autogenous bone from the canine eminence. You can see it here. We're packing that over top of the buccal and over top of the threads that are exposed. You can see on the right-hand side an extender that has been placed into the implant for one of these preformed titanium mesh. A number of Korean companies make these, and this is what we packed first, a xenograft, and then one of these preformed titanium mesh before closing with a collagen membrane. You can see the tremendous external resorption that occurred and how far down the root it was, and how wonderful cone beams are for showing us these lesions and determining before we do the surgery as to whether the tooth is restorable or not. And in this case, obviously, it wasn't. The case is ongoing. You can see the placement of the implant on the right-hand side with the membrane in place, hence the healing cap is not all the way seated because there has to be a space there. And here's a 2-week healing in this ongoing case. One of the exciting things that's happening with all lasers is low-level laser therapy. The diodes that so many of you own can be used at very low settings to improve wound healing. There are studies that show now in the last 3 to 5 years that a diode laser used at low settings can be an effective modality for reducing postoperative discomfort and promotion of wound healing. It is also effective for tissue repair and for pain relief. This particular study showed that the SEMs of the diode laser could show that low-level laser therapy may increase bone repair at the early stages of healing. So how exciting for implant therapy. So when we look at the low-level laser therapy, we have to ask ourselves, when would we want to use it? Well, perhaps in those cases where the implants have poor initial stability and we require improved bone healing in those periods. So they've used it for every 2 days for the first 2 weeks and found an improvement in stability, bone-to-implant contact, and new bone formation. How does it work? Well, the low-level laser therapy doesn't actually cut, and if you see the near-infrared light will actually be absorbed in cell mitochondria. And these cell mitochondria release ATP, nitric oxide, and reactive oxygen species, which create gene transcription. And this gene transcription is responsible for a growth factor proliferation, cell proliferation and motility, and an increase in extracellular matrix deposition. The reality is what it does is it improves wound healing and tissue repair, it decreases inflammation and edema and provides pain relief, And very exciting, it also provides neurogenic pain for those situations where a patient has problems after the initial surgical procedure. Unfortunately, it may not happen in your practice, but we all have situations where we have a neurosensory deficit after surgery. And the traditional mapping out of the area to watch it simply does nothing for the patient's comfort that this will go away. So how nice to have a tool for you, be it a lingual paresthesia or perhaps a mental paresthesia, mental foramen paresthesia, that you can have something that can increase nerve function and improve the capacity of myelin production. Let me share with you a case of my own. 2 implants were placed. This patient came back after 6 weeks and said, "I'm still numb." At this point, she was very upset. She's a psychiatrist, and she was very upset and said, "I'm not sure that I want the implants to stay in there. I want them out." So we were able to take the diode laser over without a tip, just with a barrier over top. And for 2 minutes of time, every 2 days, for the next 3 weeks, we used the laser. And every time she said there would be a period of activity where she felt great. And as the relapse came back, it was always less of a deficit than there was before. What happens, the discomfort went from a 6 to a 7 to a 1 3 weeks later. And fortunate for me, this allowed us to finish the crowns and be able to put the crowns in place in a case that might not have otherwise been salvaged. So low-level laser therapy is gaining a great interest, not only in diodes, but also in Nd:YAG lasers as well. Lasers have become popular in uncovery. We'd all love to one-stage our implants, but unfortunately there are times when all of us have to bury our implants. And lasers can be used for the uncovery process. They can be used from the simple uncovery, where you just remove the overlying tissue, to creating a buccally positioned flap. I've had some tell me, "I just use electrosurge," and I'm going to tell you, please don't. Massey, in his study in 2004, did a study on 20 implant cases that were failing, which could not be removed. 3 seconds without anesthetics of using the monopolar electrosurge, and 2 weeks later, they were able to remove all the implants with 35 Newton centimeters or less, with minimal bone necrosis. And they suggested this as, in fact, a reliable, quick, easy, and safe method for fixture removal. No, indeed, if you're going to do this, a laser is a much better tool to uncover your soft tissue. And you can do it, as I've showed here in this particular article, with just removing keratinized tissue over top. You must use this in the posterior areas because your tissue will be removed and not moved. Here's a particular case where I had to bury an implant. Patient came back, and at the 3 months interval, we're exposing the soft tissue in the posterior area using a diode laser at about 1 watt or less. Romanos has showed in his studies that 15 to 20 seconds of continuous energy, particularly at higher settings, can cause greater than 10 degrees Celsius rise in threshold of temperatures. So I would tell you to periodically put a little bit of water on to cool the site. We took our impressions in an open tray format. And upon 2 weeks later, you can see the healing here, and you can see we're then ready to place our implants, or replace our final restoration. Indeed, this can also be done with an erbium all-tissue laser. A trapdoor flap, as this group has showed, can buccally reposition your tissue for increased zones of keratinized tissue. You can see here a case where we had 3 implants. The anterior one, we were able to have enough attached tissue. And the 2 posterior ones, I simply lifted a trapdoor, moved the tissue over, took our impressions for the provisionals, and 2 weeks later you can see the granulation is occurring from the palatal aspect, but we've had an increase in attached tissue on the sites that you see on the 2 distal implants. The final restorations were created, and they were cemented in place with a nice zone of attached tissue on the 2 distal implants. There's the final post-op Panorex. So let's spend the last 15 minutes I have here on peri-implantitis. It's an exciting role that many of you will have no experience with because I'm sure all your patients are healing. But unfortunately, it is a situation we are noticing of greater frequency. Since 2008, if you look at lasers and peri-implantitis, you will find almost 50 articles, and almost half of them are from within the last 3 years. When you ask yourself, what is an ailing or failing implant? What is the definition? Well, I can tell you what the definition is not. The definition definitely is not that the ailing implant is one that I have done, whereas the failing implant is the one that was done by the practitioner sitting beside you. No, in fact, I can tell you that Mish says that a failure is an implant that has pain on function, mobility, greater than 50% bone loss, and uncontrolled exudates such as pus or bleeding, or if it's no longer in the mouth. So if we eliminate the failures and look at the ailing implants, we have two diseases. We have a mucositis, which is only in the mucosa itself, and we have a peri-implantitis that is not only in the mucosa, but is in the supporting bone. Studies have shown that mucositis is treatable in many ways, but unfortunately, peri-implantitis is a much more difficult disease to eradicate. Attier, in his study of looking at 504 studies, concentrated on 9 particular studies and found that, in fact, almost 2/3 of participants had mucositis, and it involved almost 1/3 of the implants. If you look at the role of peri-implantitis, fortunately, it is affecting about 1 out of 5 participants and about 10% of our implants. What are the etiological factors for peri-implantitis? Well, there are numerous ones out there, including poor oral hygiene, occlusal overload, inadequate zones of attached tissue, smoking, excess cement, which Wilson has shown can be responsible for 81% of cases, diabetes and other systemic factors, and an implant perhaps placed too far buccally. If we look at the categorization of treatment of implants, we can see that early implantitis is probing depths of less than 5 millimeters and loss of bone of less than 2 millimeters. Often these can be treated non-surgically with antibiotics. But traditionally, when we get into the moderate zone, greater than 2 millimeters and 6 to 7 millimeters of probing depth, surgical flap, detoxification, disinfection, and degranulation, followed by greater guided bone regeneration and connective tissue grafts, are the chosen forms of treatment. When you get greater than 50% bone loss, many people will suggest to you simply take the implant out. So we want to focus on the moderate group. The biggest difficulty in implantitis is detoxification of the implant surface, and currently there are 2 alternatives available. Those that are chemical, that involve things like citric acid, chlorhexidine, and antimicrobials, or mechanical removal that involve things like air abrasion, implantoplasty, and lasers. When we look at the traditional treatments for peri-implantitis, they either fall into a closed flap group, which Renvert has showed not much success with, or a surgical open flap, where Lindy has showed more promise. We focus on using a diode laser, or any laser wavelength, in a closed flap treatment for non-surgical. There is a study from Roncati that showed with half a watt of continuous wave, or 1.0 watts of energy for 5 to 6 minutes, followed by hand scaling chlorhexidine rinse, repeated the next day, that there was a 5-year follow-up showing maintenance of the result. They suggested conventional non-surgical periodontal therapy with the adjunctive use of a diode may be a feasible alternative to the management of peri-implantitis as a first step. Why might this be working? Well, they suggested the diode laser might be detoxifying the root surface. It might be hemostatic and weaken the calculus bond, allowing for easier removal. The diode laser also is promoting fibroblasts and osteoblasts, increasing collagen production. And so they suggested that this was perhaps one thing that you could try for early cases, early treatment. Tomorrow, Dr. Stephen Brown is going to be focusing on the role of the ND-YAG laser for something called LaPIP. Dr. Dawn Nicholson and her group has looked at 26 cases, of which they focused on 16 final cases. As you can see here is the Salama brothers, Maurice's particular case. And what they found is that all of them showed an increase in crestal bone when using the ND-YAG and decreased probing depths. And the conclusion was that there was a control of infection in all cases, reversal of bone loss, and rescue of the incumbent implant. Again, done in a closed flap nature. But remember, please be careful, because using lasers for a long time underneath a flap can cause increases in temperature. And studies have shown that in 1 minute or less, that you can reach beyond the critical 10-degree threshold that can be damaging both to your fixture and to the surrounding bone. This particular study, recently completed by Al-Falaki and her group in the British Dental Journal, looked at using an erbium chromium, an all-tissue laser with a radially firing tip. They looked at 28 implants in 11 patients, all with probing depths of greater than 4 millimeters. They used a radially firing tip I talked about earlier that has 85% of the energy going laterally and 15% of the energy going below. They took probing measurements both at baseline and at the short intervals of 2 and 6 months. And what they found is that there was no removal of prosthesis needed, no occlusal adjustment, and no adjunctive microbials. The procedure involved removing the inner wall of the pocket first, detoxifying the implant surface, and then deepithelializing the outer surface to about 5 millimeters. The study concluded with the fact that both bleeding and probing depths were decreased significantly at 2 and 6 months. And the conclusion was that it's a promising treatment, but we need more analysis. Let's turn our attention in the last 10 minutes or so here to the surgical treatment of periimplantitis. Fromm and his group are really acknowledged as the gold standard. In this particular study done in the IJPRD, he looked at 51 cases with a mean follow-up time of 3 to 7.5 years. His protocol is to do a surgical flap for visualization, to debride the area with curettes, and then to do a surface decontamination, which was a 6-step protocol I'll show you in the next slide. Following that, enamel matrix protein was added, bone grafts were necessary, and subepithelial connective tissue grafts before primary closure. When you look at the protocol that he uses, it takes about 5 to 6 minutes, and it's also fairly messy because it involves 60 seconds of air abrasion, a rinse to clean, 30 seconds of tetracycline paste with a cotton pellet, and then another 60 seconds of air abrasion, followed by chlorhexidine, gluconate, and another 60 to 90 seconds of sterile saline. So everything but the kitchen sink to try and detoxify the implant surface. How can lasers perhaps be used for this detoxification process? Well, Burke and her group in 2013 published an article that showed tremendous removal of the biofilm. You can see the laser clean portion up above and the control part with the biofilm below. The macro results were confirmed by the SEM, where you can see that the laser, where it stopped, the biofilm continues. This exciting research, they concluded that perhaps the laser could be used for peri-implant treatment for the removal of the biofilm. But they actually cautioned us and said better understanding of osteoblasts to this clean surface needs to be done before they could suggest this as a mechanism. There's been 3 excellent studies in the last 2 years done in IJPRD looking at the role of erbium lasers to predictably disinfect implants. This Japanese group in their first study looked at whether tie-unite surface could be removed completely by an erbium YAG laser. They looked at 3 critical criteria. The first being, was there an optimum power density that could be used to remove the tie-unite surface? Did it overheat the implant? And finally, were the microexplosions that were present from the erbium laser cleaning the surface enough to allow reosseointegration to occur? What they found is that at minimal settings, the tie-unite was not completely removed, and high settings would actually damage the titanium. But in the yellow, the middle setting would actually remove the titanium, remove the tie-unite, but not damage the underlying titanium. And you can see this both in a macro view on the left, where the erbium YAG surface has been used to remove the tie-unite, and on the right-hand side, it was confirmed by the SEM studies. When they looked at heat buildup, they found that it was only a 3 degrees Celsius rise in temperature if you used water. But if you didn't use water, within 15 to 20 seconds, you get a 30 to 33 degree rise in temperature. And with a CO2 laser, within 20 seconds, you could get a 50 degrees Celsius rise in temperature. So the point is, use water. When they looked at the stripped surface on your right-hand view in Figure 3C, that is the erbium YAG stripped surface. And over the next 4 to 6 weeks, they noticed bone forming in, and what they said is this clean surface, osteoblasts could re-osseointegrate to the stripped surface. So after this study, in December or November of last year, in the same journal, they looked at a preclinical study using foxhounds. What they did in this study was they wanted to determine whether the laser, the same laser, could be used to treat periimplantitis that they created on the contaminated titanium oxide surface, and what would happen to the inflammation in the soft and hard tissue afterwards. They actually took out, and they had 3 groups. The first group, they took out the teeth, extracted them, and went back in 60 days later and placed implants. The second group, they placed implants into immediate extraction sites, and the third group was a control group. They didn't let complete osseointegration occur because they put a retraction cord in around the implants and then went in and used the laser at the settings that they had determined from their first study. They used a composite bone graft and a resorbable membrane, 50% autogenous, 50% xenograft, to cover this up. When they sacrificed the foxhounds, they looked at the histology, and they found in the first group, where the implants had periimplantitis on healed ridges, there was a 3.5 millimeter vertical increase in bone, and attachment occurred to great levels around the implant. In the immediate extraction site, there was good bone-to-implant contact, but perhaps not as good as in Group A. But in the third group, they found very poor reosseointegration of the site. So they concluded that, indeed, the implant that you had could have vertical regeneration. And what they found in the conclusion was there was no soft tissue inflammation at all, and they termed the conclusion that there was an arrest of the disease progression process. So now it was time to turn these studies to humans. And in January of this year, in the IJPRD, they looked at 2 cases, combining erbium YAG laser and also antibiotics. And what they found is that in these 2 particular cases with significant periimplantitis, they were able to reverse the process completely. You can see in this particular case, tremendous bone resorption on the left-hand side. And when the flap was opened up, you can see that they had to clean out these sites. And they were able to graft the bone and get 7.21 millimeters of vertical and 4.22 millimeters of horizontal bone graft around this. After 10 months, they went back in, and they found that the clinical findings at reentry was that there was significant bone-like tissue. And when they added a connective tissue graft here, they were able to save this particular case and salvage it at 10 months. Indeed, even Fromm, with his traditional way of looking at periimplantitis in 2014 online, has shown that he's also using the laser now to detoxify his implant surfaces. Here's a case of his with significant bone loss. The laser was used in the middle photograph, and an enamel matrix protein and bone graft was added. 1-year follow-up you see here shows tremendous bone growth in a vertical direction, salvaging what was otherwise a very, very poor prognosis. Again, the follow-up is short here, so the question remains, what about long-term follow-up? Well, my friend Robert Miller has been using lasers for a long time, much longer than I have. So he has a 10-year case here, where in 2004 he wrote an article on the erbium chromium wavelength, and his conclusion was that it demonstrated no damage to the titanium substrate. He placed a case here in 2001 and noticed that in 2004, when the patient returned, there was significant periimplantitis around the 2 most medial implants. The second implant he was unable to salvage, but the first implant, the most medial implant, in 2004 he did treatment with the laser, and you can see the immediate post-op in 2005, and the 10-year stand-up that 2014 still shows the implant in place. So I hope my final word here is that I have shed some light on what lasers perhaps could be doing for implant and aesthetic dentistry. I'm not telling you it's a replacement, I'm telling you it's an adjunct. In addition, there's recent literature on the benefits of lasers for implant therapy that needs to be substantiated in more peer-reviewed journals and not just laser journals. And in addition, there's exciting recent articles in IJPRD that shows that lasers are perhaps very promising in the field of periimplantitis for the disinfection of implants and for the removal of infected surfaces, as well as for allowing for reosseointegration integration to occur. This has been one of the highlights of my professional career. I want to thank again Team Atlanta for this tremendous opportunity. It's a very daunting task to stand in front of a group of such an esteemed crowd. And hopefully I've been able to, in lasers, share some stuff with you. And in laser light, I want to say thank you.